Hey everyone, I'm Helen. I'm one of the doctors on the JEM committee. I'm an F2 doctor in Harrogate District Hospital, and I graduated from Leicester University 2 years ago. So today I'm going to be doing the cardiac arrest recap lecture. So hopefully you can remember a little bit from the last session. This should just be a little bit of a recap and make you feel ready for JEM Day 2. So I'm just going to share my slides. And hopefully you can see that. So this is a really good session because often when you are working as a doctor or a nurse on the ward, you're asked to see an unwell patient. The first thing you need to do is try and find out a little bit of history about the patient. So why are they in hospital? What's been going on the last few days? What medication they're on? And why are they concerned about this patient at the moment? What are they unwell with, or in what way? When you're meeting a patient for the first time, it's really good to use a standard approach to assess them, and that approach is the A to E assessment. So I'm just going to give you a few seconds to try and remember what A to E stands for, and then we'll go through it. Okay, so A is for airway, B is for breathing, C is for circulation, D is for disability, and E is for exposure and everything else. And it's in this order, as this is the most, order of importance. If you lose your airway, you're going to arrest much sooner than if you have a bit of tummy pain or soreness, and that you might find on exposure. For each of the A to E, there are ways to assess it, such as taking a blood pressure or taking a blood sugar reading. And there's interventions we can do, such as starting some fluids or taking some blood tests. So once you've seen your patient and you've done an A to E, hopefully you've stabilised them, but sometimes that isn't the case. If you haven't managed to stabilise them, or if you've been called to an unresponsive patient, that can be a bit of a surprise, but also there is, again, an approach we can take. So the first thing we need to do is to shout for help. It's really hard to manage these patients on your own, and you need a team around you. So the best thing to do is get some help. So when you're shouting for help, we don't want a little bit of a help, help. You need to be really shouting, help, can I get some help? To make sure that you got someone on board very quickly. The next thing you need to do is to check their breathing. So what we do is we do a head tilt, chin lift, like that, and check their breathing by looking, listening, and feeling if they're breathing. So putting your head next to their face, if you can feel it, see it, and hear it. And then you can check if they're breathing. And we're going to check for about 10 seconds. We don't want to waste much longer, as if they're not breathing, we need to start treating them as soon as possible. Whilst we're checking for breathing, we can check for a pulse. So what we need to do is check for a central pulse. And what that means is a pulse close to the heart. So we normally check the carotid pulses. We can also check the femoral pulses. And we do this because it's more likely that you can feel a pulse close to the heart than further away, such as a distal pulse in your radius, that might be lost if they've not got very good circulation, but they are still conscious. So if they don't have a pulse, then we have confirmed cardiac arrest. So in this case, we need to follow the ALS algorithm. And basically what this algorithm here shows, we'll break it down and go through it over the next 20-30 minutes. But what we need to be doing is doing CPR. We need to be checking the rhythm. And we need to either be given a shock or giving medications, as the algorithm suggests. So if you've confirmed cardiac arrest, what you need to do is you need to drop the bed. So that means the bed's flat and low so that you can get good access to the bed. And then you need to start CPR. So if you've got a few people around you, you can ask someone to CPR. If you don't, and it's just you start CPR whilst getting help and shouting for help or pulling a buzzer. Once someone arrives, you can ask them to call 2222 and ask for the cardiac arrest team. And you need to make sure you're asking for the appropriate cardiac arrest team, as there's normally an adults cardiac arrest team, a paediatric cardiac arrest team, and an obstetric cardiac arrest team. You need to make sure you've got the right people arriving. Amongst the cardiac arrest team, there might be an anaesthetist, there might be like a medical registrar, an ODP, which is an operating department practitioner. There might be some F1s and F2s on the team, and a few other people, perhaps a critical care outreach team member, a porter if you needed things bringing, and the site manager as well, things like that. So whoever's on the phone to the double twos needs to make sure they give the precise location. So that is the ward, the building, and the hospital. I can remember being at a arrest once, and unfortunately the arrest call was put to the wrong location and we had to wait a long time for our arrest team, and that was really not ideal. So once they've called 2222, you can ask them to bring the cardiac arrest trolley. And this is a big trolley with all the equipment you should need to run an arrest, and it's all organised from A to E as needed. And then, like I said, we need to make sure we're doing good quality, effective chest compressions. So that's one of the trolleys. You can see it's kind of labelled, and it's got the different things in different sections. On top of it is the defib, which comes in very handy, as we'll discuss later. So when you're doing chest compressions, what you need to do is take the butt of your hand and place it at the base of their sternum. You can put another hand over the top, and I often interlace my fingers, but some people put them flat. And what you need to do is extend your arms out so they're locked at the elbows and your shoulders, and you need to be pushing with your whole body weight, pushing down about 6 centimeters, or about a third of the chest. You need to make sure you're keeping your arms stretched straight, so you're not just doing this, because that's not going to put any pressure through. You need to have your arms locked out, and it should look something like this. So when you're doing your chest compressions, what's really important is once you're pushing down, you come all the way back up to allow the chest to recoil. You need to continue at a rate of about 100 to 120 compressions per minute. And that sometimes people use songs, Staying Alive, Ellie the Elephant, things like that to keep them in time. It's really important that you're getting it around right. You don't want to go too fast or too slow. And when you're doing the compressions, you need to do them at a ratio of 30 to 2. So that's 30 compressions to 2 breaths. We don't do mouth to mouth anymore, but that will be breaths provided by a bag valve mask. So that's one of the valves that goes over, and you've got a bag and you can press that to give them a breath, or they might have a more definitive airway in if an anaesthetist is about or someone's felt confident, we can give them those breaths. So next steps, we need to carry on the chest compressions, make sure those are going in good quality the entire way through, and then we need to attach the defib. So someone needs to be monitoring the defib, and we need to turn it on, and we need to check what the rhythm is. So when we're checking the rhythm, we need to make sure no one is doing compressions at that time, as that can distort the rhythm on the monitor. While someone's manning the defib, we also need someone to be manning the airway and giving those breaths. We need someone to be doing the compressions and someone ready to swap in. We need someone trying to get some IV access to give any medications via cannula and to take some bloods to check what might be caused the arrest. And we need someone to be managing the arrest, and they need to be managing it from the end of the bed so they can see all the team members. Whoever's managing the arrest, it's really important they use closed communication, closed loop communication. So when they're asking something, they need to ask one person specifically, please can you, Helen, get the access to make sure nothing's missed. As often in an arrest, someone might say, oh, we need to get fluids, but no one knows who's getting the fluids. So it's really important to use that kind of closed loop communication. Okay, so once we've got the defib on, we need to decide whether we can shock or not. So this is a rhythm, and I hope you can remember from your last session what this rhythm is. So I'll give you a little bit of time to have a look and decide whether you think you can shock this or not. So this is VF, and VF is a shockable rhythm. So what we want to do is switch the defib on and give them a shock. What about this one? So this is what they might refer to sometimes on Grey's Anatomy as flatlining. It's never quite a flat line. This is asystole, and this is a non-shockable rhythm. And then you've seen this on the monitor. What's that mean, or what do you want to do? So this is electrical activity, and what we need to do is we need to check if they've got a pulse or not, because this could be compatible with life. If there is no pulse, then it's called pulseless electrical activity, and this is non-shockable and needs to be managed with medications. So to summarise, you have some shockable rhythms, including VF and pulseless VT, and you need to give them a shock at 200 jolts or whatever the local guidelines is. There are some non-shockable rhythms, such as asystole and pulseless electrical activity, And what you need to do is you need to give them 1 ml of 1 in 10,000 IV adrenaline immediately, and then carry on with the algorithm. So on the defib, there is a timer, which is really useful because we manage these patients in cycles of 2 minutes. So every 2 minutes, at the end of the 2 minutes, we need to do a rhythm check, and we need to check, are they now shockable if they weren't previously, or have they gone from shockable to non-shockable? We need to decide whether we need to give them any more medications, or we need to check if there's actually some electrical activity that might be compatible with life. So during the cycle, we carry on with our compressions and breaths at 30 to 2, and we start thinking about any reversible causes of arrest. We make sure we've got IV access and we've taken blood tests and blood gas, so we can look and check if there's anything else we need to treat. And we keep the compressions going till the end of the 2 minutes, where we'll do a rhythm check. At that point, we'll give any medications or shock as appropriate. We need to make sure we're not checking the rhythm while someone's doing compressions, as, like I said before, that can affect the rhythm that's showing, and it's not showing actually the rhythm of the heart. Okay. So, as I mentioned before, there are some reversible causes of cardiac arrest. We refer to these as the 4 H's and the 4 T's. So, the 4 H's are hypoxia, hypothermia, hyperkalemia, and hypovolemia. Hypoxia is when you don't have enough oxygen in your body. So how we manage this in arrest is that we give them oxygen, a high flow oxygen, via either the bag valve mask or a more definitive airway. You can use airway adjuncts, which help us get a clearer airway in and provide the oxygen. Hypothermia is another cause of cardiac arrest, and what we can do is we can gently warm the patient using things like blankets or bear huggers, which is a big device that kind of has warm air. Or if they've got more severe hypothermia, we might consider other things such as warm fluids. However, it's very dependent on the patient and the department and the degree of hypothermia. There are some studies that suggest a small amount of hypothermia might be beneficial in arrest situations as it protects the brain. One of the other causes is hyperkalemia, and that means they've got a high potassium. So certain medications might cause you to have a high potassium, or if your kidneys aren't working so well, you might have a high potassium. And there are a few other causes. And what we can do with that is we need to lower the potassium. But the first thing we need to do is actually stabilize the heart, as a high potassium can cause the muscles in your heart to get a bit irregular and cause irregular rhythms, and that's what's kind of led them to the arrest. So what we do is we give a medication, either calcium chloride or calcium gluconate, to try and stabilize the heart. And then we give them some medication to try and bring that potassium down. And that we often use insulin, which is used in diabetes management, or we use salbutamol, which is used in asthma management, or a few other things to try and bring the potassium down. The last thing is hypovolemia, and that is when you've got a low circulating volume, so there's not enough blood or fluid going around and circulating. So what we can do is we replace the volume with either IV fluids, so we might give them a bolus of some fluids. And if we think they've been bleeding and that's why they've arrested, so they might have had some incident, they might have been in some trauma, then we can give them some blood to try and replace that circulating volume. And often we'll give O negative as the universal donor. But initially we often give them some fluid first because that's quicker than getting some blood, and that'll help try and replenish that volume as soon as we can, and then we'll add the blood in. Okay, so the 4 T's are tamponade, tension pneumothorax, thrombosis, and toxins. So tension pneumothorax is when there is some air in the sac around the lung, and that's stopping the lung from expanding properly. So the lung can't perfuse as well and ventilate as well. So what we can do in that case is we can do something called needle decompression, where we insert a needle into the area, in this area of safety, which is around here. And we pop that needle in to try and let the air out to allow the lung to expand again and ventilate properly. Tamponade is a similar kind of principle, where there is a kind of fluid or blood around the sac, in the sac around the heart, so it stops the heart expanding and pumping properly. And we can do a similar kind of thing with a thoracentesis, where they pop a needle into the area and they drain that fluid away to allow the heart to pump effectively and get the blood circulating around your body better. Thrombosis might be a case of a pulmonary embolism, which is a clot on the lungs, or it might be an MI, so myocardial infarction, where there's a clot in your coronary arteries. And what we can do in those cases is we try and either break down the clot, such as in pulmonary embolism, we might give thrombolysis to break that clot up, or in myocardial infarctions and STEMIs, what we do is we can do PCI to try and open up that blood supply to the heart again. And lastly, T for toxins. Some medications may kind of build up and cause arrest, or some drug overdoses might cause arrest as well. And what we need to do is find out what kind of medications they've been on, so checking their medical chart is really important, and checking if they've come in with any kind of overdose or things like that. And we use a website called ToxBase to look at all these medications and see if there's anything that we can do to try and reverse the act of it. Okay, so in this scenario, you've done a really good management for their arrest, and you've managed to get a ROSC. So that is a return of spontaneous circulation. So unfortunately, that doesn't quite look like how it looks in the film. We don't have these people gasping and waking up and talking immediately, often because of the arrest, and they might be arrested for a long time. There's still a lot of damage there, so they might actually still be unconscious, but have a pulse again. And a lot of these patients might have some lasting damage, so they might need further investigations, like blood tests again after they've arrested. They might need things like a CT of their head to check if there's been any brain damage. And they might still need support breathing, so they might still be ventilated, or they might need other support as well. So these patients are often best looked after in the intensive care unit. Following an arrest, what's really important is for the staff members involved to have a debrief. And that might be an immediate debrief, which is called a hot debrief, where you do it straight after. Or it might be a cold debrief, which might happen a few days, weeks, or months later. So one of the useful tools that we can use to debrief is the Take Stock tool. First of all, we do our introductions, make sure everyone's there, and then ask, is everyone okay? Sometimes people have been affected by the arrest situation more than others, and they might just need to take 5 minutes, take half an hour to just, take a break, breathe, look out for themselves, and just kind of get back to feeling ready to go back to work again. So they might need a break. We need to know, is there any equipment issues? Is there anything that will need fixing before the next time? Often the resus trolleys will need restocking if we've used all the cannulas and things like that to try and get access. What we'll do is we summarise the events and then talk through the things that went well, and then talk about the things that might not have gone so well and what we could do next time to try and improve. We need to decide whether a cold debrief in a few weeks or days or months is necessary. And that might be if something went not so well, or if it was a pretty traumatic case, things like that. And then we just need to make sure we know who's present. So if there is a cold debrief, they can get there. Okay, fine. So I hope you enjoyed that. That was just a quick recap of the cardiac arrest. And I hope you feel ready for JEM Day 2, where you might have to put that into action. All right, thank you very much.